So, I renew my thanks to the organizers, all the organizers for the invitation, and for the opportunity to talk about this topic, which is actually not completely new, but which is getting more interest lately. Well, commonly, when we talk about robotics in urology, most of us think of these platforms. However, most urologists still don't know that in the last 10 years nearly, some robotic platforms have been developed for the endoscopic treatment of renal stones. But devices like the RoboFlex and the User for some reasons, didn't get much luck. Well, today there is a new kid on the block in this scenario, which is called the ILI robot. As you can see, as with the previous devices, once more we have two elements. Once again, we have a robotic arm, but most importantly, you see that the cumbersome master console of the previous devices has been replaced by a simpler and lighter wireless controller. Indeed, the robotic arm is remotely controlled by the wireless joystick. It is fixed to both the flexible uretheroscope and the urethral access sheath, but most importantly, the robotic arm is compatible with any type of urethral access sheath and any type of flexible uretheroscope which is now available on the market. It is not so difficult to understand where the controller comes from. And this is a schematic view of how the joystick works. Basically, we have two sticks. The left one allows to move the endoscope forward and backward, whereas the right one allows two types of movement, upward and downward deflection, and clockwise and counterclockwise rotation of the endoscope tip. By pressing the X button, we activate the movement of the laser fiber, which is then moved forward and backward through the R2 and L2 buttons. So, can we start the video, please? The videos. Okay. So this is the whole robot. As you can see, two items, the robotic arm and the joystick. Soon after switching on the robot, the first thing to do is to select the type of urethral access sheath and the type of flexible uretheroscope you are going to use. After that, we can connect the joystick to the robotic arm, and as I said before, connection is wireless. You see that there are no cables between the two elements of the robot. Now let's see some movements of the robotic arm without the endoscope on site. This is the movement that allows the deflection of the endoscope tip. This is the place where we will fix the handle of the endoscope. And this is the rotation movement. As you can see, a 360 degrees rotation in both directions. The most distal part of the robotic arm is where we will fix the urethral access sheath. As I said before, by pressing the X button, we activate the movement of the laser fiber, which is then moved forward and backward through the R2 and L2 buttons of the joystick. So the surgery starts as a standard retrograde intrarenal surgery. Patient is in lithotomy position, and once we have placed the access sheath, the robotic arm is approached between the legs of the patient, and the access sheath is fixed to the most distal part of the robotic arm. After that, we manually introduce the endoscope into the renal pelvis, and once the tip of the endoscope, the video accidentally stopped. Can we restart the video, please, and go to the point where can we go to the, okay. We fix the handle to the robotic arm. We just a bit over the previous point. So you see that the screen of the robot shows us the degree of deflection and the rotation of the endoscope, which is very important because as we do not have the endoscope in our hand, we have no more tactile feedback. But the robotic arm is fixed to both the endoscope and the access sheath. So while we move the endoscope through the robot, we are sure that the access sheath remains still, and this prevents potential lesions to the urethral to the urethra. The movements are very fine and precise, which allows us to progressively dust the stone from the peripheral to the central part. But movements are also quite immediate, which means that the latency time from the movements of our fingers on the joystick and the movements of the endoscope is quite imperceptible. Of course, at the beginning, it is not so intuitive to understand how to make the endoscope do what we would like to do, how to use the joystick and how to move our fingers on the joystick to perform the movements that we have in mind, the movements that we would do if we handled the instrument, but it's only a matter of practice. In other words, it implies a very simple and short learning curve. So in this case, despite the attempt of completely dust the stone, in the end some small fragments remained. And so, as you will see in a moment, we switched to a popcorning strategy. Right now, we are still performing dusting, but you see the movements are very fine. But in a moment, you will see that some small fragments remain. So we switched to a popcorning strategy, which I must say is particularly useful with this robot, because the robot keeps the position of the fiber among the fragments and far enough from the mucosa. In this phase, the robot is still, so also our fingers on the joystick are still, and we performed the popcorning by only pressing the pedal of the laser. And by doing that, that was the result of our treatment. In the end, the stone was completely dusted, and there was no need for fragments retrieval with a basket. This is the end of the procedure. So we can proceed with the undocking. Firstly, we remove the endoscope. After that, we detach the urethral access sheath, and the undocking is done in just a few seconds. Lastly, I would like to show you some images which actually come from another patient who had a stone located into the lower calyx, because I found that this is a particularly suitable condition for the ILI robot, where we can benefit the most from its stability. Indeed, in this case, firstly, we deflected downward the tip of the endoscope, then we placed the fiber nearly in the middle of the lower calyx, and the whole treatment was performed by only pressing the pedal of the laser until the stone was completely dusted. So a quite comfortable surgery in this case by using the robot. Okay, so what are the advantages of using the ILI robot? Firstly, good ergonomics and comfort, which is, as you know, a milestone of robotic platforms. Secondly, safety for the surgeon, who can sit at a higher distance from the sources of X-rays. There is no more cumbersome master console, so less space needed in the OR. As I said before, the robot is adaptable to any type of access sheath and flexible urethroscope available on the market, so once you get the robot, there is no need to change your instrument. Higher precision during treatment thanks to very fine movements and firm stabilization of the tip of the instrument, and higher degree of movement, especially for the rotation movement. And what are the potential disadvantages? Firstly, we need some time to dock and undock the system, but actually this is not a real limitation, because you need just a few seconds to do that. The lack of tactile feedback, which is, as you know, the historical limit of robotic platforms. And as I said before, the controller doesn't reproduce the movements of the hand, so you need some time to understand how to use it in order to make the movements that you have in mind. And last but not least, the cost. These are initial already published experiences on the ILI robot. Of course, these are single-center experiences with very low numbers, and most importantly, no comparisons to the standard retrogrointorhinal surgery, but however, promising experiences with good subjective perceptions by the surgeons. And this is our personal experience in Como. We treated 6 patients using always the same instruments, Mean stone size was 13 millimeters, mean total operative time of 43 minutes. You see that the mean time to dock the system was 40 seconds only, and we experienced no complications, no technical problems, and in each case, complete dusting with no need to fragment retrieval. And to conclude, of course, the ILU robot is, as I said before, the new kid on the block in this scenario, but technological developments are ongoing with new emerging devices like the so-called Monarch robot. This is a multi-specialty platform, so designed not only for urologic procedures. Again, you have an Xbox type controller to move the endoscope. Again, the advantages are stability, ease of navigation, ergonomics, and reduction of radiation exposure. But the aim is also to develop some new softwares for automated actions like size detection, laser settings, and electromagnetic targeting. Thank you.
Okay, Davide, just one question because we need to move on to the OR with Dr. Scofone. So the point from I'm speaking from a lay point of view because I don't have experience at all in robotics and for stone disease, but it looks like a little bit more difficult than doing it on your own. So how to convince, beside the money-wise, which is a drawback, no, the money, how to convince people that it's really helpful for surgeons and it's going to improve and it's going to be not cost effective, but at least effective, more effective than the one we're used to doing?
Well, about efficacy, actually, we still have to demonstrate everything because we don't have studies, but just a few points. Firstly, if we do not try this device, if we don't operate patients, if we don't collect the data, how are we supposed to demonstrate that there is an advantage compared to retrograde renal surgery, standard one? Secondly, if you're asking me, do you really need the robot? The answer right now is no. But I tell you another thing. When the Da Vinci, for example, came out, probably the questions were the same. People were asking, do you really need this robot to perform the same surgery that until now we have performed with the laparoscopy? And the answers were usually, it's more comfortable, it's easier, the learning curve is lower. So probably, in my opinion, we should give a try. We should give this robot the opportunity to demonstrate if it is really worth it. But we can do it only if we use it, only if we collect data. So if we start by saying it's useless, there is no future.
You know how many centers are using it and collecting data in a prospective database around the world, worldwide?
Still a low number. I don't know exactly the number. In Italy, a couple of centers, as far as I'm concerned. It's difficult. I know that it's difficult to accept also for the costs, but there are some ideas to develop this robot. For example, the idea of integrating a uretheroscope. Once you have the robot with its own uretheroscope that you can reuse, the problem of the cost is lower. But to develop a machine, you have to use it, try it, and give some opinions on what could be done.
Okay, so the future in stone disease is very promising, and I think we have to wait for this data in order to see if it's really worth the money that
yes,
you need to invest.
That it costs.
So thank you, Davide, and we big applause.